Today, we're diving into a really critical connection that can sometimes get overlooked in a busy clinic: the link between a new diabetes diagnosis and a potential underlying cancer. We're going to explore when this very common diagnosis might actually be pointing to something far more serious. And look, this isn't just a theoretical question. For the patient sitting in your exam room, getting this right could be life-saving. We're going to unpack when high blood sugar isn't just a metabolic problem, but a direct signal from a hidden malignancy. So picture this classic scenario. You've got a patient who just doesn't fit the typical mold for type 2 diabetes. They're not obese, they're a bit older, and bam, the onset is sudden and it comes with unexplained weight loss. Your diagnostic alarm bells should be screaming, because this isn't just diabetes. It's a puzzle that needs solving. All right, here's how we're going to tackle this puzzle over the next few minutes. We'll start with this new way of thinking, then look at the culprits, both the tumor and the treatment. After that, we'll build a practical diagnostic toolkit and wrap up with why collaboration is so crucial. Okay, first things first, we have to completely reframe our approach here. We need to shift our thinking from diabetes just being a risk factor for cancer to seeing it as a potential symptom of cancer. That's a huge change in perspective. The key term we need to get comfortable with is dysglycemia. It's really just any new or unexplained weirdness with blood glucose. The crucial takeaway is this: that abnormal blood sugar might be the very first clue your patient gives you that a cancer is brewing. This slide really lays it out perfectly. For years, we've all known the old story, right? Diabetes raises cancer risk. But the new story, the one we really need to focus on, is that this is a two-way street. The cancer itself, or the drugs we're using to fight it, can directly cause diabetes. It's this two-way link, this loop, that we have to be able to spot. So what's actually driving this? Well, it really boils down to two main culprits that we need to investigate: the tumor itself and, of course, the treatments we're using against it. Let's dig into the tumor first. All right, let's talk about the absolute classic example, the one every clinician needs to have on their radar: pancreatic cancer. Seriously, new-onset diabetes, especially in a thin, older patient, is a massive red flag for a hidden pancreatic tumor. And check out this timeline. It shows you just how early the signs can appear. The metabolic shifts can actually start 2, even 3 years before a cancer diagnosis. And then in that last year, wham, the patient develops full-blown diabetes. If we recognize this pattern, it gives us an absolutely precious window for earlier detection. But listen, it's not just about the tumor itself. That's really only half the story. The powerful therapies we use in oncology are, more and more, being recognized as direct causes of this dysglycemia. This is what we call iatrogenic, or treatment-induced, hyperglycemia. This table breaks it down so well. You've got your steroids, which are probably the most common culprits, causing those classic blood sugar spikes right after a meal. Then you have these newer, targeted therapies, like PI3K inhibitors, that directly mess with the insulin signaling pathway. And then, and this is a big one, immune checkpoint inhibitors can actually trigger a full-on autoimmune attack that just wipes out the beta cells. It can cause a really sudden, severe, insulin-dependent diabetes. And the list just keeps on growing, We also have to keep an eye out for unpredictable effects from neuroendocrine tumors and the newer agents like antibody-drug conjugates. You just never know what you're going to get, which means proactive monitoring is absolutely essential. Okay, we've laid out the problem, so now what? Let's put this all together into an actionable toolkit that you can actually use in your clinic, starting tomorrow. These are the red flag scenarios you absolutely need to watch out for. First, that sudden diabetes in a non-obese older patient we talked about. Second, a patient whose diabetes was stable for years and then suddenly goes haywire. Third, any new diabetes that shows up with other big symptoms like weight loss. And finally, of course, any hyperglycemia that pops up right after starting a new cancer therapy. Any of these should make you suspicious. So here's a really simple 4-step game plan. Step 1, screen your high-risk patients before you even start treatment. Step 2, know your drugs. Anticipate their specific patterns, like those post-meal spikes with steroids. 3, when the hyperglycemia hits, don't wait around. Jump on it with insulin early. Avoid that therapeutic inertia. And 4, always keep a low threshold to screen for cancer when you see a weird case of diabetes. And finally, and this might just be the most important piece of the puzzle, you can't do this alone. Managing these patients, it's just too complex. It has to be a team effort. Look, getting the best outcomes for these patients really demands a tight collaboration between oncologists and endocrinologists. It's just that simple. The oncologist knows the cancer therapy inside and out, and the endocrinologist is the expert in glucose management. It's by working together that you can really navigate these tricky clinical situations. And it all comes down to this one single idea, which this quote just nails. Not all diabetes is metabolic. Sometimes it is oncologic in disguise. If you remember one thing, remember that. So I want to leave you with this question. The next time you see that high blood sugar reading on a lab report, ask yourself, what am I going to look for beyond the A1C? Because the answer might not be in the metabolic panel. The answer might be in the search for something else entirely.